Hello and welcome. Thank you for joining this webinar looking at the new ONS Health Index, a national measure for health. I'm Jo Bibby, I'm Director of Health at the Health Foundation. And just before I do my intro, a couple of housekeeping things. If you have any technical problems, please put them in the Q&A and we'll try and help you. And also we have a hashtag if you want to tweet about what you hear. It's hashtag THF Health Index. So welcome. Everyone on this call, I'm sure will know only too well that good health depends on much more than a first-class healthcare system, and that health is shaped by our circumstances and the chances and opportunities that are available to us. We also know that too often the urgent need to keep pace with demand for healthcare squeezes out the important need to invest in the things that keep us healthy in the first place. The same short-term decision-making creates a bias towards fixing problems when they become visible rather than preventing them. We see this whether in housing, criminal justice, employment or climate change. So how to incentivize long-term investment needed to create the condition for healthy lives is the challenge facing anyone wanting to improve people's health. So this morning we want to consider, can the ONS Health Index create the incentives needed to focus attention on improving health and action on wider determinants of health? Published for consultation last December, the index brings together a range of upstream and downstream measures to provide an assessment of both how healthy people are today and how likely they are to be healthy in the future. Over the next hour, we have a chance to hear three perspectives on the index and the potential it offers. First, we'll hear from Dame Sally Davis, currently Master at Trinity College, Cambridge, and who first proposed the index when she was Chief Medical Officer. Sally will share with us the origins of the index and her thoughts on its potential. Second, we'll hear from Dr. Johnny Pearson-Stuttart, public health doctor and epidemiologist at Imperial College London, and also the Vice Chair at the Royal Society of Public Health. Johnny was a member of the ONS Health Index Advisory Group and will be able to provide a more in-depth tour around the index. And then we're going to hear from Dr. Moona Abdelaziz, Director of Public Health at Salford Council. Moona is going to share her thoughts on the opportunities the index presents for leaders in local government. After we've heard from each of them, there will be an opportunity for questions and answers from the panel. So please do put your questions in the Q&A and I'll be pulling out questions to put to the panel at the end. So I'm now going to hand over to Sally to start us off.
Thank you, Jo. So why a health index? Well, the idea for this arose from my independent Chief Medical Officer annual report that I published at the end of December 2018 with Johnny Pearson-Stuttart, who will speak after me, as the chief editor. And what we looked at were four main areas about where health could be in 2040. We looked at repositioning health as the nation's primary asset, creating an environment that prioritizes health, emerging technologies, and futures thinking so we're well prepared for the future. Actually, by the time we'd done the work with a lot of experts, who I want to thank yet again, who were wonderful, we were really optimistic that we could really make a difference to health if we worked together and took the broader view, and if people recognize that health is a component of human capital and a key component, and we made the case, then surely people would want to do something. And in this report, we proposed the Composite Health Index, because what we showed was the inequalities that I think most people on this call will know. And in fact, we've highlighted, Johnny and I, in our book published in November, Whose Health Is It Anyway? But one example is the life expectancy between the most and least deprived increased from 6.1 to 7.9 years in women and 9 to 9.7 years in men over the period 2000 to 2016. So there's been a debate since Black, Aitchison, and Marmot about health inequalities. And almost a feeling they're there, they're intractable, we can't do anything. Yet, of course, our impact on smoking as a nation, reducing prevalence by 70%, says if you're action-oriented, you can. And we argue that the metric of life expectancy, which measures the health system as a whole, actually is measuring far more, but is always a lagging indicator. So based on, I think it's Drucker, but the management guru who says what gets measured gets done, we began to think, how could you have a composite health index that actually opens the conversation for doing something? And we proposed that it needed a basket of measures, which included social determinants of health, modifiable risk factors, things like overweight and obesity, and healthcare, things like cancer survival. And that we needed this transparent and accountable health index. We wanted it as a framework. We wanted it at the national level, but that it could be disaggregated to regional, local authority, and ideally borough level, so that one could look at how things were going and what was happening. We think that that creates an opportunity to have discussions and comparisons and look at metrics of success. We believe that if you can start to see how you're impacting on these things, it can drive innovation for improvement or catching up. It tells you who you can learn from. And actually, it gives us a real focus on inequalities and should get the government not only to talk and think about what to do about inequalities, but to have that cross-government view. So we're doing, as we said we wanted to do, in that annual report, positioning health as an individual's primary asset, but also of the nation, a primary asset. I was delighted when the Health Index was commissioned from the Office of National Statistics, and I can only encourage all of you to join in the consultation so it's as good and as useful as it can be. I'm really looking forward to this discussion, and thank you, Joe, to you and the Health Foundation for hosting this. And now over to Johnny to show you the Health Index.
Thank you very much, Sally. And again, thank you, Joe and Health Foundation for hosting this event. So I'm just going to share my screen now. Thank you. So as Sally mentioned, the purpose of the Health Index was to measure health rather than just illness, in the knowledge that that contributes to economic prosperity at local level, individual level, but also nationally. And so there were three domains to the Health Index. The first is that healthy people layer, and that's predominantly of health outcomes, things like healthy life expectancy, cancer survival, etc. These types of things that we do measure and hear about a lot within health already, those health outcomes. The second aspect are those risk factors, things like smoking rates, obesity, education and working conditions, those drivers of ill health, but there can be drivers of good health too, and often that we call the social determinants of health. We know that all of these are predictors of future health outcomes, but make up the stock of an individual's ability for their health, to be able to work, to learn through education and so forth, and be happy. And finally, the healthy places, which are these wider drivers, some other social and commercial drivers, things like green space and access to green space, crime or distance to services. And the idea was each of these three layers contribute to the stock of an individual's, a community's or a nation's health. Some of them will lead to ill health sooner than others if they're not treated, but that all of them contribute to the ability to live well for longer, and that provides the opportunity of health and education and employment opportunities. So as Sally mentioned, the ONS published the first version, the beta version, for the years 2015 to 2018 in December. The idea is that this will be updated hopefully quarterly, but certainly every 6 months, and much more recent data, so that in the summer it will have 2020 data, for example. And here gives an overview of the initial findings. So what they did with the Health Index is they took 2015 as the start year. So the index and all of the domains at the national level, that's England level, are at 100 in 2015. And if they go up If they're higher than 100 after that, that means they've improved. Below that, they've got worse. And similarly, when disaggregating and looking at regions or local authorities, if they are greater than 100, they're higher than the England average. That's healthier than the England average. Lower means worse. And what we found is you can see this middle line is the health index, and that it increased ever so slightly for the first 2 years and then declined in 2018. But again, the purpose of the index is to be able to dig deeper, not just to define the problem, but to see why, how that's made up. And you can see there's quite different trends here, with improvements in the healthy lives domain, quite substantial improvements there, but some declines in both the healthy people and the healthy places domain continuing throughout. But even just looking at that domain level, it masks what's going on underneath. So if we take that first layer, the healthy people domain, within that there are several subdomains too: mortality, physical health conditions, mental health conditions, physical impairment and well-being. And what you can see here is even within that healthy people layer, there are quite different trends. So anything that's flat on the 0 line has stayed the same over the last 4 years. But you can see quite big improvements in well-being over this time. Smaller improvements in mortality and physical impairments, but really worrying declines in both physical and mental health morbidity over that period. Now, this already speaks to what the purpose of the health index was, is that if we were just measuring mortality, just measuring life expectancy here, we would be missing all this that's making up the morbidity and the ill health that people are experiencing during their life, the impact on their lives and on wider society. But to go much further, the ONS partnered with Lane Clark Peacock, where I'm head of health analytics, to create a health index explorer that could be much more interactive, so we can dig down to say, how does my area compare with another area? Why is it different? Which are the domains of the health index that have changed over time? And that provides these actionable insights. So if we can see 2 areas that we think should have similar stocks of health, which parts of the index, are they the health outcomes? Is it the healthy places or the healthy lives? Which of those are different and what we can do about them? And so here now, I'm just going to play a video, which hopefully should come through now, which gives you a little tour of the index and shows a bit more detail. More detail as to how the index has changed over time, how it varies across England, but then actually explain why this is the case according to different domains and indicators. So the first thing we can see is that the current index from 2018 is 99.7, and that's declined since 2017 and down since the first year, where it was 100 in 2015. And just at first glance, we can see there's a real difference, with much of the northern areas being in orange and red, and that suggests lower than the England average, and many of the southern areas being more green, being healthier than the England average. But we can explore a little bit more as to why that is the case and what's happened over time. So here we look at the England index, how that's changed since 2015 to 2018. And we can see there the index, as we mentioned, 100 in 2015, it increased and has declined since. But of course, the index is a composite measure and made up of very different components. We've got the healthy lives domain, which is around risk factors, healthy places, those environments that we live in, and the healthy people, our health outcomes. If we were to look at healthy lives, you can see actually that the healthy lives component has increased over this period by about 1 unit. And you can see actually that that's a much more sort of even picture across the UK, with some poorer areas over in Shropshire and so forth. But if we look at healthy places, that's declined slightly over this period, with some quite large declines in the first year in 2016, and then some modest declines since, and again a much more mixed picture across the country. Whilst the healthy people domain has actually seen the largest decline over the past 4 years of 1.9 units. You can see year-on-year declines, and the areas that have done worst, with areas like Northumberland and Doncaster seeing some of the largest declines in healthy people domain over the past 4 years. So we can explore a little bit more into why that is. The areas in red have had the worst declines, whilst green has seen an improvement. And you can see that mental health, and specifically depression, has seen some substantial declines over the last 4 years. The same can be said for physical health conditions, and specifically for musculoskeletal conditions and for cancer outcomes. Whereas we have seen improvements in personal well-being, with indicators such as life satisfaction, worthwhileness and happiness improving. On the healthy lives aspect, you can see some of the most green areas are those that have improved the most after over the 4 years, and that's actually in children and young people's education, with indicators such as early years development and GCSE achievement improving the most. And this goes to show with these types of indicators that may not ordinarily be associated with health, just how important they are for the stock of health across the nation. We can look how this varies by region. And as you might have seen on the map there, the southeast has the highest health index and has done throughout, with the northeast being lower. And we can explore how that changes according to the domain. When we look at healthy people, it's actually London who have the healthiest outcome there, again though with the northeast at the bottom. A not dissimilar picture in healthy lives, the northeast at the bottom, with the southeast at the top. But interesting, when we look at the healthy places domain, the reverse is true, with the northeast having the healthier places and London the least healthy. But quite striking is when we come to create our own analysis here, where we plot the health index of all of the 150 local authorities, each of them which are represented by a dot, with the health index on the y-axis here. So anyone in the top right-hand corner here is both the healthiest populations, but also the least deprived. As on the x-axis here, we have the index of multiple deprivation. So this bottom right-hand corner is showing the least healthy local authorities, which are also the most deprived. So you can see quite a staggering difference between Blackpool, with a health index of 86.4, to Wokingham of 110.1. And then a trend in between of generally the most deprived the community, the poorer their health index. If we look at that by the different domains, there's quite an interesting picture. Now, there is some correlation still here, with many of the most affluent areas still having the highest index in the healthier people domain, but it's much less stark than that overall index score. And that could be suggestive of the role the NHS plays in providing equitable service and to reduce those inequalities. In contrast, when we look at the healthy places domain, there's much less of a correlation between the health index score and deprivation. And that's really interesting, because for some of these issues, such as, for example, the density of fast food outlets, we know that they are much higher in more deprived areas. But that must be countered by issues like access to green space and affordability of housing. But really interesting is when we look at the correlation between deprivation score and healthy lives. And the reminder, the healthy lives domain looks at risk factors such as smoking and obesity and so forth. And here you can see a striking correlation again, with Woking with 117.1, the score for the healthy lives, again down to Blackpool and Knowsley with scores below 90. A really striking correlation in those risk factors that we know are so important to health outcomes, but also the ability to work and enjoy day-to-day life. But finally, what we can also do is that we can look at specific areas and compare them. So for example, if we look at Newcastle upon Tyne, which is the city that I was born, and we might compare it with, for example, the city that Sally was born in. Sally was born in Birmingham, so we can select the West Midlands and Birmingham. And what we've got here is a comparison of, in 2018, the health index in Newcastle and how it compares with Birmingham. Domains that are in green are healthier in Newcastle, whilst domains that are in orange or red are less healthy in Newcastle and healthier in Birmingham. And it's interesting, you can see areas like access to services, but also public green space are healthier in Newcastle upon Tyne compared to Birmingham. Whereas when we come over towards the healthy people aspect, and we look both at some of the mortality outcomes, such as avoidable deaths, mental health outcomes, but also in the disability that impacts daily lives, Newcastle is doing much worse than Birmingham is. There's quite a mixed picture between Birmingham and Newcastle when we look at healthy lives. There are some areas, such as the physiological risk factors, and that means things like diabetes rates, obesity rates, that Newcastle seems to be healthier than Birmingham. Whereas in other areas, such as those behavioural risk factors, which include drug misuse and alcohol, Newcastle seems to be less healthy than Birmingham. So you can explore in here how any local authority compares to another, and you can see the ranking, with Newcastle being 123rd out of. Thank you. And so that's on the Explorer, you can go there and look how your local area differs to others. But as Sally mentioned, this is an experimental statistic under consultation for 3 months, so about 6 or 7 weeks more. So it's designed very much to get the feedback as to how to make this most useful to whatever role your role is across health or wider than that. And one area is to make it much more local, from upper tier local authority to at least lower tier, but how it can be more useful to local decision makers too. And with that, I'll hand over to Muna.
Thank you very much. And I'm really pleased to be sort of looking at the health index from a point of view of a local authority and local area, whether it's from a local government, but also from a public health perspective. So I'll share my screen now, and I just hope that it works through and clicks through very easy. Hopefully you can see this now. Right. Okay, so I'll present the view from one of the local areas, and Johnny actually just compared Birmingham with Newcastle. And in Salford, for example, we would compare with our statistical neighbours, and we would compare with our geographical neighbours, because we do work really closely together in Greater Manchester. So this is what you'd expect from any area. Our ambition for health and well-being in Salford, it's about starting well, living well, aging well, but also about Salford as a place, our Salford. And the way we look at this is very much an asset-based, a positive viewpoint, where we articulate the outcomes in terms of a positive viewpoint of healthy, fulfilling lives. And our core outcomes are articulated really, as Johnny had said, with a negative side, which is looking at life expectancy and gaps in life expectancy and health inequalities. So the more that we can talk about health as a positive asset, I think that will mean that partners are more willing to engage with the work, because they can see the relevance to them. Just as a small example, the relevance of health to the economy. So back to that chart which Johnny did show in the video, where we charted the health index compared to the index of multiple deprivation. So these measures were taken at approximately the same time, let's say 2018, 2019. So they are talking about the same population groups at a point in time. And we can see this level of correlation between the index of multiple deprivation, which is aggregated across a number of domains, including health within that. And you look at the health index, which is also aggregating across a number of domains. So Salford is the 18th most deprived local area in England, and it is still sort of, it does feature as having poorer health than the average for England, 93.8 in 2018, and it breaks down healthy places, healthy lives, and healthy people. So in my talk, I wanted to look at each of these domains and say, okay, what does this domain mean for us in Salford, and how does it add new information to us, to the information that we already are monitoring, we already are seeing? So traditionally, we measured health. Of course, we looked at deprivation. So there is a series of maps here of Salford, and you can see with the colors that the darker colors are actually, the negative side of a measure. So they are where people are more deprived. The map in the middle is about the index of multiple deprivation, mapped down into LSOA areas. So this is measures of health within Salford. And then the map to the side of that in blue is looking at long-term illness and disability. And again, it seems to be following that same pattern. And looking at our outcomes for male life expectancy and female life expectancy, you can see with the red color, that is those areas that are more deprived are seeing the sort of the poorer health outcomes. I did say that within the index of multiple deprivation, there's a health and disability domain. And that has changed in time between 2015 index of multiple deprivation and index of multiple deprivation 2019, but you can see that it hasn't shifted very, very much. So we do want to look at changes over time. And healthy life expectancy, if that was the only indicator, if that was the key outcome that we were looking for, the healthy life expectancy in Salford is 5.5 years, sort of 5.5 years poorer than the national average. And it has remained unchanged since it was first measured in 2009 to 2011. And when you look at the index of multiple deprivation through that timeline, you'll see that, well, there is a different index of multiple deprivation way of being calculated in 2015 to the way it was calculated again in 2019. So again, you can see that the way we measure health if we change the way we measure health, that makes comparison a little bit difficult. However, the trend is still the same in Salford. There are still the same proportion of individuals living in our most deprived areas, but it's just the way in which we've measured them. In 2015, it seems as though suddenly we've got more people who are more deprived, and that isn't the case. That's an artifact of the way the IMD measure changed. And then if we look at how we compare Salford to other areas, well, the trend in Salford's deprivation rank, it has actually, it has become sort of slightly better in being the 18th most deprived in the country, in 2019. So you can see a very big change in the trend of our range of where we fell amongst all of the other local areas. When you look at the Health Index, I think the marvelous thing about this is that it anchors to a point in time where all the places are comparing to that point in time. So you get that comparison, which is fairer across time, but also fairer across place. So again, I've put into this slide the index score for place and index score for outcomes. And then deep dive. Let's just look at starting well in Salford. And the way we traditionally look at this is we've got a range of health measures that Public Health England publish, and the way it's presented it will be familiar to people who are looking at the Public Health England fingertips. So this is the child health profile. But when you look at it from the Healthy Lives perspective, of course, it looks a little bit different. It doesn't look as professional, you know, kind of like technical. So this health index is one that you can talk to local communities about. And particularly because it is asset-based, is measuring good health, then again, it's a more optimistic way in which we can start to talk with our communities and start to co-produce some of those solutions that they are ambitious for, that we are ambitious about, to improve the health of the people of Salford. And when you deep dive into the Healthy Lives domain, then you can also see how Salford ranks for low pay, how Salford ranks for emotional health and well-being for children. And this is a call to arms, really. This is a very simple slide that people, members of the public, wherever they live, can look at. And you know what their first question will be. But I don't live across all of Salford. I only live in one of the neighbourhoods. So what's my neighbourhood look like? And I think for us, that's where we'd want to see the health index go, where local people can compare where they are in their neighbourhood within a borough. And then if you take a macro and step back, the way Johnny and Sally had spoken about, the whole ambition about a health index was that we were able to measure change in time across place. And we do this beautifully with the health index. And I think that we could even use that for a sort of asset-based measure, which is a positive measure of health, to fine-tune some of the funding that ought to be going to areas across time. And we need to use a measure that changes, so it has very sensitive change over time, so that, you know, life expectancy takes years to change. Tackling health inequalities take a long time. We want to be measuring those small wins, and we need to see these changes on a yearly basis, being able to celebrate and say, look how well we've come along in 12 months, and that the funding should follow that. So you know what? This has been a year. 2020 is worth 20 years. And this is just a graph that shows impact of COVID in Salford and the way we've been through a first wave and a second wave, and now we are well into our third wave. So, I mean, how do we look back on this point in time? So we can look back on this point in time by comparing it to 2015. And we can also look forward with the new information that we will get in future. So, for example, in 2021, we will be getting information on the census that will also start to measure the impact of the pandemic. We're starting to have conversations with our local residents about a big health and care reset. It's a big conversation which we've just had in December. So we want to talk to our local communities about how we can shape the health and care system in Salford in future. So I'll just pause here now, because I know that this has just literally been the viewpoint of someone responding to the consultation on the health index and what we would like to see it enable us to do. In summary, we'd like the health index to help us talk to our local communities about the greatest asset that they have, about their places in their neighbourhoods, broken down within Salford. Thank you.
Great. Well, thank you very much to our speakers there, and thank you everyone for all the questions that have been coming through on the Q&A. Now, I am going to try and field some of those to our panel members, and there are a couple though that I can just answer straight off. So there's been some questions from several people about the methodology for creating the composite indicator, the weightings and so on, and whether details of this is available. And just say, yes, it is. On the ONS webpage, you can find a link through to the consultation document. And in that document, there are technical annexes that explain the methods being used. And I know ONS are very keen to hear comments on those aspects of the index, as well as broader things around its composition and use. Another question that's cropped up a few times in the Q&A is around this being for England at present, and what are the plans for the devolved nations. And again, just to say that I know that's something that ONS are starting to consider as they move into the next phase of development. There are quite a few other technical questions, and I do know that some ONS colleagues are actually on this webinar. So actually at this point, I'm going to really encourage them to start fielding some of the more technical ones, if that's possible. But let me turn some questions now to the panel. And I'm going to start, Sally, with you. Going back to what you said, you talked about the index positioning health as an individual's and the nation's primary asset. And I think that's something lots of us on this webinar will share as an ambition. My question is the index enough on its own? And what else would you want to see in place, or does there need to be in place in order to create the right incentives for its use?
Well, I think it is the first building block of what we need. I was fascinated how Muna said this will open conversations within your local authority for you to have. And the way I saw this was that it would open conversations in government. But until we get an acceptance that actually health is now more important as a capital asset than education in your future, employment and life expectancy, we aren't where we need to be. So I think there's not only what do you measure and how do you have that conversation, but there's something about communication. What it might also be worth picking up on, our object is to have this next door to the GDP. So it's discussed at that sort of regular level. We have high ambitions for the health index, that people should be thinking about it and talking about it regularly. But the GDP, of course, measures flow of money and flows in and out and expenditure. What we are measuring here with this health index, and I think Munya actually spoke to that, is the stock of health in our communities. We're talking about how healthy people are. So from that perspective, it will be different, but it needs to be up there to have that conversation at every level.
Great. Okay, thank you. Now, a question that's come up in a number of forms that I was going to direct towards Muna and Johnny was just asking about the relationship between this and the IMD, and if you could expand a little bit more on the sort of value add you think this has over the index for multiple deprivation. So, Johnny, could I ask you to talk about that first?
Yes, of course. Thanks, Joe. And the IMD, of course, Index of Multiple Deprivation, again, is a composite measure of deprivation, and so that we can look at inequalities. And there are various domains in there. Health is one of those domains. And so whilst the IMD is that measure of inequalities, of composite of types of things that make up inequalities, the health index looks at health. And so the measurements are the measurements of health, or drivers of health, or the drivers and drivers of health. Then within that, we were very keen that you're able to look at the inequalities in that. So whether that's by region, by local authority, or to plot that by a measure of deprivation, which the IMD is one of, if not the best measure that we have regularly within data sets and so forth. So it's important. And the second side, as well as the health index obviously being focused on health, and then we can look at how those outcomes, risk factors and places, how equal or unequal they are. What it's very keen for it to be is it's not just seeing that bucket. So in the IMD, we see the health bucket, the crime bucket, and each of the different buckets. again, in the health index, you can see the healthy lives bucket, the places bucket, and the people bucket. Then you can go further down and further down again and further down again. And we were very keen, and the ONS has done a fantastic job in making sure this is explainable. So why is there a difference between the health in my local authority and next door's local authority? Which are the indicators and why? And that enables itself to be more likely to be acted on, rather than it just be, there's a big difference in inequalities in health outcomes. We're not really sure why.
Una, do you want to add anything to that?
Yes, and I think from my perspective, health is an asset. But when we talk about the NHS, for example, we talk about illness and we think about needing care, whereas a measure of health is actually much more speaks to people's assets. And saying to someone that you live in an area that's the most deprived area in England, when actually they are the most resilient people, they've got huge assets, even at their doorstep. It's almost like disadvantaging them just by way of labeling. So I do welcome the index of health as opposed to an index of deprivation. Mathematically and technically, of course, in the way they're presented, they may overlap hugely, but it is entirely a different positioning of health that an index of health will bring.
Great, thank you. Okay, there's another question that's popped up in a number of ways. People were struck, I think, when you showed some of the data about the trends in well-being relative to the trends in mental health and physical health, and the fact that well-being did seem to be showing improvement relative to the others. I just wondered if that's something any of you would like to sort of hazard some sort of hypotheses around that. Johnny, I think you look like you're ready to go.
I'm glad to start, and others may want to add, Joe. So it's what's important to note is what the sources of the data are here. So ONS have been very keen, of course, for the sources to be very transparent. They're all publicly available data, or largely publicly available data. Now, the well-being data, as I believe, is from is survey data from the Societal and Personal Wellbeing annual survey. So these are largely self-reported measures of well-being, whilst the physical and mental ill health morbidity aspects and the mortality are either, so mortality, for example, is obviously from death statistics, whilst physical and mental ill health conditions are from things like the Quality Outcomes Framework and other measured and diagnosed conditions. Now, that explains why there's differences in the data, and there may be differences in who responds on a survey versus clearly the data that's picked up. But I think it's a really interesting finding, because a lot of people until now have said that well-being could and should be the measure of overall health. And perhaps this shows that that as a measure isn't enough, because it's quite divergent to others and could be missing some clues underneath.
And if you look in the question box, Greg from the ONS has given an answer as well, which is really helpful, at 1:37 p.m.
Right. Okay.
Sorry, could I just come in on that point around mental health and well-being? Because when you look at mental illness, the response, or even physical illness, the response is care, and we need to make sure that there's got health and care in there, but also prevention. So they are really worthy of a lot of focus in their own right, because they are more as a measure of morbidity. But I think the measure of well-being gives us the optimism. That's what I was explaining, by people feeling extremely resilient and being able to, you know, tackle up head on all of the challenges that face them on a day-to-day basis. So that sense of optimism is actually a measure of resilience that we ought to also keep hold of.
Great, thank you. Okay, I'm going to move on to another question, which is asking how the index could be used to encourage business to step up to their role to contributing to health of the nation. So, you know, I think this is something we're familiar with, the role that business can play as an employer and investor, the products and services it provides. Do you feel the index provides the right measures to engage and incentivise them? Is that something you would like to see different in the index? Muna, did you want to start?
So I think a business at the moment, because of the knock to the economy, we do need measures of business resilience. So we've been having conversations locally to look at how we can boost community resilience and business resilience at the same time. And that is by making sure that our small and medium enterprise, businesses are thriving, and that they have local customers, and that they have local people into those jobs. So that will be a win-win. I think for me, that's where the conversation starts, about bringing in a health index and a measure of business resilience alongside each other, and have that conversation between the both parties. That's where we can find the win-wins. That's where, where our visions coalesce.
Right. Sally or Johnny, anything to add to that?
Well, clearly business, the private sector should be part of this discussion. And I think this is a great starting point at the local level, because what we want is businesses as employers to support both their employees, their families, and their communities, as well as produce products that are health enhancing, shall I say. Now, this won't be able to do everything, this index. I'm sure people can think of all sorts of things they want to use it for, but it does start that discussion. The question is how you put teeth into this, and I think that's very difficult. I think that goes back to a policy intervention, and I go back to Johnny and our book that we published in November, Whose Health Is It Anyway, where we actually address that and say that companies should be investing in health at every level, and if they don't, then they should be paying a levy into a public health investment fund, so that that money is available locally and nationally to improve health.
Great. Maybe this is a good point to move on to a couple of questions that have related to whether or not there's a case for having targets around the index. So the government does have a target on increasing healthy life expectancy by 5 years, but I'd be interested in reflections on whether or not there needs to be any more specific goals or targets attached to this, and how it might sit with that healthy life expectancy goal. I think you'll probably all have something to say on that, but Mona, could I start with you?
So I think at the moment, for me, the health index doesn't break down sufficiently locally for us to consider whether we would want a target that compares us to any other areas, or how one area contributes to a massive whole across England, for example, to make up the national target. But I think the way that we could be thinking of this is having some process targets, or, for example, how can we use the health index for health impact assessments, for example, or for health inequality impact assessments, and to which extent are we using health index and all the other rich local information to inform key decisions that are being undertaken locally and key decisions that are being undertaken nationally. So I wouldn't be able to comment on the mathematics of developing a target and whether a target would be appropriate. I'll leave that to others, because for me, it's still, there's a journey with this health index. But as a starting point, making sure that we are using it in our health inequality impact assessment alongside our equality impact assessments.
Okay. Johnny, any thoughts on how this might link with targets?
Thanks, Joe. I think so. I think Mona outlines it very nicely, that at the local level we need to be even more granular on the data to enable any locally led targets. But at the national level, I think a very simple target is, as Sally mentioned, we'd like this to sit alongside GDP. Now, every government, when they're running for in the election for the next election, will always talk about what's happened to GDP in their time. They'll talk about what's happened to unemployment. Now, wouldn't it be nice if the next number was what's happened to the health index? And we at local level can say, my own area, you've improved the health index over the last time, you've improved healthy people and healthy lives. So it's a very easy, target to say, in terms of, without going into any maths. We started at 100 in 2015. We're already below that. Wouldn't it be nice that the target is to get back and improve the stock of health as soon as possible at the national level? Sure.
And Sally, I wonder if, turning to you, I could just add a sort of supplementary to it, which is, there's been a few questions in the chat about, one was whether this could be monetized, the index could be monetized, so it's expressed in a currency that perhaps Treasury might engage with, or just generally people are interested in sort of what interest there has been from Treasury. So I just wondered whether there's anything you could reflect on there.
It could be monetized. I think one of the big drivers for us was the discovery that employment and therefore productivity within our nation relates to health more than education, because until a few years ago, it was much more about education. If you were well educated, you got employment and you were better paid. Now you've got to have health as well as education, and health is even stronger. So it does matter to the Treasury, and they are quite interested in this. And how they will use it, I think, depends on how we can show them how useful it is. So I was part of the discussions about the healthy life expectancy target, because I wanted us to move away from life expectancy. We need people to have good lives, not long lives. It's important to support them to have good lives. And that's why that was there. And this takes that a stage further. It's beginning to look. And what building on what Johnny said, what I can imagine is people saying, as a target, we want to get back to a health index where we were in 2015 within 1 year or 2 years. Then we want nationally to steadily rise, and we want everyone at the local level to look what they can do to get things to plateau and then to start to rise in each of their 3 areas: healthy people, healthy lives, healthy places. And of course, pollution's in there. So things that really matter to people's everyday lives and their health are in there. So it gives you an opportunity at the local level to say, not only should we legally respond to pollution and make sure our children are safe, but it impacts on our health index. So we need to do something about it.
Right. Okay, so I think, we're coming towards the end of this. So I've got 2 questions that I'm going to put round all 3 of you, slightly more general ones. The first one is, somebody's asked, how can we mainstream this? So just from, your vantage point, it'd be good to hear a couple of things that you think need to happen for the index to be mainstreamed into people's use. So again, Muna, I'm going to start with you.
Yes, thank you. So I think from my point of view, I think it's being part of a joint strategic needs assessment every year that health and wellbeing boards undertake and compare where we are compared to everywhere else. That's a start. And then I also mentioned the way that we could use it to for our decision making around health impact assessments or health inequality impact assessments, and responding to planning applications, responding to licensing applications, and particularly if we're able to break down the index to areas within Salford. So I think for us that'd be the starting point. Thank you.
Johnny.
Thanks, Jo. I think for it to be mainstream, it clearly must be usable and useful, and the information that it's providing must be able to be acted upon to improve it, and it to be relatable to whoever that user is. And that's quite a broad ask, and that's why this consultation is so important, and that the ONS very much, this is not the end, and that this is an iterative process, because the body of work that's gone onto this is huge, and it would be such a shame if this sits on a shelf somewhere, because it does have the potential to provide those insights to how we act specifically. And then the final aspect is, clearly most of the people on this call are in the health sector one way or the other, but as Muna mentioned, that health is that asset to each of us individually, in our communities and so forth. And so much of that then is, especially given what's happened over the last 9 months and the links with health or ill health, education opportunities and employment, that actually is this a really good opportunity for the health index to be brought into, to show that we're building back after this pandemic and reducing inequalities in health, and because of that in other areas in our lives as well.
Sally, what about your thoughts?
Let me start by thanking ONS. They've put a lot of effort into this, and I think they've done a grand job. Maybe it can be improved, but Greg and Susie are here. Please take our thanks back to the whole team. So I want you, every single one of you, to respond to the consultation and start by saying you think it has a role and you want to see it as an official statistics published as frequently as possible, in as granular detail as possible, and put there by the GDP. Ask for that, and then go on to how you think it could be improved, because that's what we're all about. We're trying to get this as good as it can be as an official statistic, so people start to use it. I can't believe the Treasury won't start to use it, or the Department of Health, if it's there next to GDP. But we've got to make sure ONS has that support. So appeal to everyone to respond to the consultation. Hurrah, make it an official statistics. Here's how to improve it. Thank you.
Right. Okay. Before I sort of move on to the question I'm going to wrap up on, just to point out to people that very kindly colleagues from ONS on the webinar have been responding to some of the questions in the chat. So please do look at those. The other thing is a few people have been asking questions about whether or not you can look at this, the data by age. And I think the answer is yes, it is possible to look at some of these measures, cutting it in different ways, different characteristics, population characteristics, and so on. There have also been some questions about whether it's possible to go below local authority level. At the moment, it's broken down to upper tier local authorities. I know ONS is starting to look at plans to see what it is possible to break down lower than that. But of course, in order to get the comparisons, there is the need to have consistency across different places. There's also been quite a few comments and discussions in the chat on some of the things around community assets and whether or not the index captures community assets, how well it does that. I think actually, Muna, I wonder if I could turn to you before we finish, just to comment on that, because I think linked to that, there's been an observation that although we're framing it as a health index, we're still capturing, in a sense, a lot of the things that, you know, aren't good for our health. And is the scope, can you see scope to build in things that bring more of that kind of community asset thinking?
So I think COVID has really disrupted the way we used to look at things and work with and work with our local communities. We've had to step up together and support our local residents in a different way. And we've had lots of volunteers come forward. So there is a lot of innovation and ingenuity and resilience within our local communities that we can pick up and that we can nurture. So the way we're doing it in Salford is we've got a health and wellbeing board and a subgroup that's looking at tackling health inequalities. We want to work with local communities to co-produce the solutions to some of the issues that were almost in the too difficult box. But now with COVID, knowing that we can go through such immense challenge and emerge on the other side, hopefully, you know, these are really difficult times. We have to have that optimism and the hope, and we have to be able to celebrate the small wins on a quarterly basis, even if our health index starts to edge up. So I think sadly, when we will be seeing this huge knock, not just on health, but on our economy, on education, all sectors have been equally affected by COVID. But what can we do here and now, coming out of the pandemic, sort of being able to restart some of our social activities in a safe way, of course, but these solutions could be to hand. We don't have to think of these solutions as decision makers. It's our local residents and our local businesses who can come forward and step forward to meet that challenge. And I think the health index is really helpful because it is a positive measure. And if we can track it regularly, whether we track it locally, but if we can track it regularly, it can give rise to that optimism. And it will also give us the early warning if things aren't improving as quickly as we would like. Thank you.
Great. Okay. So as we've mentioned, there are links in the chat, in the Q&A, to the ONS webpage. From there, you can follow the links to the consultation document and to the interactive platform. The consultation finishes, I think it's the 3rd of March. So as Sally says, the more people who respond to this, I think the better. But I just want to invite the panelists now just to provide some closing comments, and just to sort of as a prompt to that. The question is, a year from now, what would you like to hear people saying about the health index? Johnny, I'll start with you.
Thanks, Joe. Well, I think the first thing is we'd like lots of people to know about the health index and lots of people to have fed in, and so for the health index to have developed even further from here, and whether that's to go more granular in detail first, to go broader in terms of the composite measures, or devolve nations. I think there's, if the ONS was unlimited in resource, it would all happen at once, but clearly there'll be a program for that. But I think the second thing is, if it's being used regularly, whether that's locally or nationally, as to how we're improving as our stock of health. And I think public health, one of the difficulties is we invest in it and the biggest returns don't come for a few years down the line, even if some of them are very are quite quick. Whereas things like obesity or smoking cessation, they actually, if we invest in them today, they're the mediators that will see that change the health index, prove the health index, and then incentivize decision makers to be investing in prevention because they can see that indicator drive. So it'd be great to see those discussions and those actions to come through and on this sort of journey for the health index over coming years.
Great. Muna, if I could ask you what you would like to hear people saying a year from now.
So definitely, I would echo exactly what Johnny has said. I would like to use it as a conversation for prevention, as a conversation for tackling health inequalities. So I'd like the version of the health index that's coming out to be robust, to allow us to measure across time and across place, because that's the way which we can track true progress, and not to have that inconsistency that happens when you change the way you measure things. I think this is a very positive index at a very difficult time. It will help us to become more positive into the future. So it could mark the start of a new normal. Thank you.
And Sally.
So the first is a word of warning. Don't let perfection be the enemy of good enough. Feed in improvements. ONS have been wonderful. I noticed Maya's also been responding to things, and he leads the team. But go for it. What I want to see is that this is part of the currency of conversation, not only next to GDP, but actually NHS England saying, if we do this, it could change the health index in this way. The Department of Health demanding of other ministries, what are you doing on the health index? And the Treasury saying, if this is going down, we're not going to get the Treasury receipts we need, so we need to invest so it comes up. And I think COVID has focused everyone's minds and visions, as Muna has so beautifully put, in order that we have that conversation.
Great, thank you. And I smile because you also used what I was going to use as my closing phrase, really, which is, I think this is a huge opportunity. And as Sally said, you know, let's not let the perfect be the enemy of the good. We've got a real opportunity. I think those of you who have been working in this space for some time, you know, the idea of a health index is perhaps something we've talked about, never thought we would necessarily see. So, you know, all thanks to Sally and Johnny for the work they did at the department and getting it on the agenda. And as Sally says, to colleagues at ONS who have done a brilliant job in pulling something together. And so the consultation is open. Thank you to the three speakers and for fielding those questions today. Please do respond to the consultation. And I hope people have enjoyed this webinar. Thank you.